From the American Neurological Association, I'm Adeline Goss. This is ANA Investigates. Dementia is a global issue, with 2/3 of people with dementia living in low and middle-income countries. Despite this, dementia research continues to focus on patients in high-income countries. Our guest today, Dr. Riadh Gouider, is working to correct this imbalance. Dr. Gouider is the head of the Department of Neurology and the Alzheimer Center at Razi Hospital in Tunisia, and an advisor on the latest WHO Global Action Plan on the public health response to dementia. He spoke with Dr. Jayant Acharya, professor and chair of neurology at Southern Illinois University School of Medicine, about challenges and opportunities for dementia research across the globe. Here's Jayant.
Welcome, Riadh. Thank you for joining us on this podcast.
My pleasure, Jayant.
So let's start by talking about dementia prevention. So as you're aware, The Lancet recently released its updated commission on dementia, and this report describes some new, hopeful evidence about targets for dementia prevention across the globe. Do you agree that there's reason to be hopeful about dementia prevention?
I think that saying hopeful is too optimistic. I would say we know that this thing to avoid can delay dementia, but if it is written in your genes, it will appear. So I will say I'm more confident now to advise people on how to delay the dementia, how to prevent the importance of the symptoms. And this prevention is the same for the high-income and low-income country. By targeting this modifiable risk, like hypercholesterol and other risks that we know now can give you some cognitive trouble, if we work on all of this, we can delay by years. And this is, I think, a very important message. It is important because if we delay the dementia and delay the neurological consequences and the cognitive impairment, we can gain crucial years of autonomy and of public health expenditure, which are important in this case.
Now, you are one of the experts involved in the WHO Global Action Plan on the Public Health Response to Dementia 2017 to 2025. What are the major target areas that this plan has identified for preventing and managing dementia worldwide?
There was a group of experts who tried to see how we can prevent dementia. This work is just a part of several works on how to prevent dementia, but WHO is very, very committed to make dementia preventable more than it is. You know that, for example, depression is to be prevented because it will aggravate the hearing loss is a factor that can make social isolation of the person who have cognitive impairment and aggravate things. And now that had been added by the Lancet Commission, even visual impairment also is important to do this. The use of alcohol, the use of illicit substances, the use of drugs to have sleep every night are not good. We know that is not important. There are factors that are constant, and I insist a lot on them: hypertension and diabetes, because the half of the population in our country is not knowing that they have hypertension. And the half who have hypertension, half of them are not well treated. That's a set of things that WHO is working on. But also WHO is working on the diagnosis tools. And there's a commission that is seeing what are the characteristics of the best diagnosis, biology testing, or biomarkers for Alzheimer in developed countries and in developing countries. That's an example of the activities that WHO is working on, with also a lot of involvement in tools to help caregivers like I support.
So thank you for bringing out some very important points here, Riadh. So let's shift a little bit and talk about dementia research. Most of the research is actually done in high-income countries, even though most patients with dementia live in low-income countries. So, what are the major reasons for this? And what are the negative consequences, both in terms of uh, what happens to patients and the negative consequences in terms of the quality and generalizability of the research that is conducted?
Well, if we see what's going on in the developing country, as I said, the first focus of the research for the diagnosis is to have tools of diagnosis that we don't have. We were able in Tunisia or in other, I will say, little bit more developed country to have neuropsychological adapted testing. That's not the case in the majority of the regions in Africa, for example. In this country, there's few or no possibility of having a diagnosis, for example, from the CSF by the tau and beta lipoprotein variations. You don't have specialists. For example, you have country where you have one neurologist for 1 million inhabitants. And there are countries where there are less. So these people are simply under the huge charge of the daily care, and they don't go to research. And if we go further, there's some peculiarities that are in this population. I will take, for example, the northern part of Africa. In this region of the world, the recessive pattern, the inbreeding, the marriage between cousins is very, very common. It's culturally the trend in these countries. And we know in our families in Tunisia, we are conducting genetic research that there are more recessive patterns in our families than what is published in the world. We have shown that this pattern of recessive is leading to even a different pattern on the neuropsychology side. No one can conduct such research because inbreeding is not in all the world. In the developed countries, we are going to precision medicine with drugs that will be related to the mutations which are more frequent in the Caucasian population, for example. But who will take care of the non-Caucasian population? That's an important fact, that the research has to be widely done in the world. One of the meetings that you will have on the near is in Kenya, which is dementia in low and middle income countries. And there will be a meeting with a group of NIH to see how we can help to study the genetic background in the African continent. The research is ongoing, and that kind of research will be very helpful to help the people who are in the continent, but also to help the people from African ancestry, Middle East ancestry, who are now living in the US, for example.
That's very interesting. And so besides this, what other changes do you think need to occur so that low and middle income countries play a greater role in global dementia research going forward?
Research, Jayant, is based on inclusion. WHO want that dementia research and innovation go forward, but it cannot, WHO that don't by its structure doesn't give finances for this. Structures like NIH, the European Commission on Research, the Japan Institute should allow the developing regions to have tools to progress in research. The benefit will be for everyone. But if you take countries in sub-Saharan Africa with a total expenditure less than $50 per person per year, what kind of research you expect to have, Jayant? It's the amounts for all the healthcare for a patient. And in these countries, with middle age of 20 or 25, Alzheimer is just something that is not important in the priorities. Helping the stakeholders to put dementia on there, to give finances for research on there, having a world network on dementia is the only way I see to progress. If not, you will have a huge difference between North and South, developed and developing country, especially with now the intervention of artificial intelligence and precision medicine.
Excellent. Thank you for sharing that, Riadh. So let's talk about some of the challenges that you have faced in your own research in Tunisia and how you have tried to address them.
The first challenge that we faced was 20 years ago when we began working on Alzheimer and were building the Alzheimer Center. So the first thing in research was to adapt the tools. I will give an example. If some Tunisian lady doesn't know who is the author of the Four Seasons Symphony, is it a cognitive impairment? No. So the first thing was to adapt this to our population. The second point is to go to the genetics. And we have proven that our population is not the exactly figure of the Caucasian population. This is now widely accepted. We have published on this results, and we are working a lot on the modifying gene in a recessive pattern. We can't compete with developed country on dominant disease or NGS, but we can study better the recessive pattern that we have. The third point is to go to non-pharmacological treatment research. We made in our center trials to see if music, for example, was helping people to be better. Physical activities and things like this, because we can't afford for everyone the pharmacological treatment. So developing countries should also invest in non-pharmacological treatment. This is very important. We made also a research on the impact of Alzheimer's disease in the family. We did it with our psychiatrists. And guess what, Jayant? 90% of caregivers in Tunisia are daughters or daughters-in-law. The sons are by far behind. So these daughter and daughters-in-law are taking care of the patient. And there's a score which name is Zarit score, which see how the person is tired, how the caregiver is depressed. Shows that after 5 years, every caregiver is depressed without any help from the family, without any help from the institutions. And we made an alarm about this. We are now working with the WHO on a support, which is the iSupport application, which is in the WHO system. We were able to translate it in the Arabic and in the Tunisian dialect. And we made training for the caregivers on the iSupport. That's the kind of levels of research. You can do clinical research, neuropsychology research, biology research, imaging research, and even, I would say, socio-demographic research on the impact of the disease in the population.
I'd like to thank you for highlighting the important role that caregivers play in the management of patients with dementia and the toll that it actually takes on them. So, Riadh, can you give us a few more concrete examples of how dementia research in low and middle income countries has improved global understanding of dementia? So, in short, how can research in low and middle income countries improve dementia outcomes for people all over the world?
Okay, I will go for an example which is due to colonization. I made my medicine in French. I speak Tunisian dialect Arabic language, and I'm also a French speaker, and as you guess, an English speaking person. The bilingualism or the multilingualism is one of the way to make cognitive impairment be late. It will prevent cognitive impairment. We know it's important. So one of the messages that we have put on our research, the more in the world we know languages, the better is for your brain. I'm very unhappy with these new tools of artificial intelligence that make you have an immediate translation. That's good when you don't know the language at all. But please, if you can learn another language, learn it. It's good for you. It's good for your brain. And it will prevent dementia by years. That's one of the examples. One of the other examples is that what has been taught, for example, ApoE profile is important. We have shown that the ApoE profile impact is different with the population of origin. So we cannot give it the most important, I would say, risk ratio. No, in other population, it doesn't have the same impact. And the work and the research in Africa will let us understand better dementia and cognitive impairment in the Afro-American population.
What concrete advice would you have for junior dementia researchers, people who are starting out, including those who live in high-income countries, who want to involve a more global patient population in their research? So how would you suggest they go about doing something like this?
If, for example, someone from United States, a young researcher, want to go in Africa and make research, that's possible. You have structures like the Africa Consortium on Dementia, the African Academy of Neurology. We can help as a university or as the Alzheimer Center to just give you advice on the network where you can be in. If you are interested in a subject which is specific, for example, I will say HIV in the African context and its impact in cognitive impairment, the use of substances, the diabetic hypertension and their impact, you can find a lot of possibilities to do it. What is missing is not the possibility to work. What is missing is the financial support to make it. But if someone can build with an African colleagues an NIH grant or a grant going through Europe that can finance this part, you will find a lot of subjects, you will find a lot of specific subjects that you can work on and that can give original results, helping to manage dementia and cognitive impairment.
So thank you, Riadh, for sharing your knowledge and expertise and for providing your insights and suggestions for both current and future research. I really enjoyed this conversation with you. So thank you for joining us on this podcast.
The pleasure was mine. I thank you to be interested in dementia and cognitive impairment in this part of the world. And I hope that in 2-3 years, we will have another podcast on this saying a lot of progress has been done on this.
That was Dr. Riadh Gouider of Razi Hospital in Tunisia, interviewed by Dr. Jayant Acharya of Southern Illinois University School of Medicine. ANA Investigates is the official podcast of the American Neurological Association. The show's producers are members of the ANA Education Innovation Committee, chaired by Michelle Johansson. I'm Adeline Goss, podcast host and executive producer. Our production team today included Jayant Acharya, Michelle Johansson, and Jen Hurley. You can listen to past episodes of the show, subscribe to us so you never miss an episode, and access all of the ANA's educational programs on the Education tab at myana.org. That's it for ANA Investigates. See you next month.